Well, good afternoon, everybody. I'm going to be presenting this vascular trauma case of the upper extremity. It's a pretty new case. It was occurred about a month ago. Things are still kind of ongoing with the patient. This was at our South Trauma Center, Jackson South, so the southern end of Miami. So I'll go ahead and get started. I have no disclosures. So the pre-hospital events with this young man, he's a 25-year-old male. He had a GSW to the right shoulder. He was initially taken to a small community hospital in Homestead, Florida. I don't know exactly how he got there, if it was just a drop off or it was EMS. But once he arrived, he did appear in extremis. He was intubated. Peripheral IVs were placed, and he was started on blood transfusions. He was given 1 unit there and then was transferred emergently to our facility in South Miami via air rescue. He was given a 2nd unit en route. And when he arrived to us, he had 1 unit currently transfusing. So on arrival, his airway was confirmed. He was intubated. He was very combative. They had given him RSI drugs. Those had worn off, and then it didn't seem like they had given him much en route. So we had to sedate him, which took a bit of time. He's a very large young man, took a lot of medications to keep him down. His initial vital signs, his heart rate was 150s. His blood pressure was 95/63. We immediately placed a 9 French introducer into his left subclavian vein. And then we started massive transfusion protocol. On his quick survey, he had a single GSW to the anterior lateral right shoulder. It did not appear to be bleeding initially when he arrived. However, once we started the resuscitation through the introducer, it started bleeding briskly from this wound. This is just a depiction of where that wound was, kind of a junctional GSW. So this is kind of the first stop point, is options for hemorrhage control from this bullet track. Just see what everybody thinks as far as junctional control, temporizing until definitive management.
Go to Portland, Dr. C.
Well, the dictum in a situation like this is stop the bleed. So you have to come up with your ingenuity, how you're going to stop the bleed here. And of course, in South Africa, they deploy balloons and drains and things like that to stop the bleed, and they're pretty successful. So if you can see the bullet hole, and if you can see the entry and the exit, and well, before you do that, you should do a chest X-ray to make sure the patient does not have any evidence of any pneumothorax or tension pneumothorax or hemopneumothorax. And once you have determined that, I think your duty is to stop the bleed. And if you can stop the bleed with deploying balloons, by all means you should. And if you're not going to be very successful in doing that, the next option is either go to the OR or go to a hybrid room. Most hospitals do not have that luxury. So I think you should go to the OR to expose the proximal blood vessel so you can get control of it to stop the bleed. And then after that, you can deploy other modalities of imaging to see what can be done. So that's what I would do initially. Thank you.
Thank you, sir. Sao Paulo, Dr. Calais.
For me, in these situations, it's very important to do the trajectory of the bullet, because this trajectory will come from the shoulder, can go into the chest and make it transfix the mediastinum, or can go to the upper and bone transfix the subclavian, and can sometimes the subclavian artery can blend it through the pleural cavity. So in this situation, you can first I need to see the bullet trajectory. you can put balloons through the wall of the bullet, like a Foley catheter or Foley catheter or the catheter, vascular catheters can use the balloon and through the hole and try to stop it. Sometimes, if you know the trajectory of the bullet, you can, if the patient continues stable, you can go in some situations, go to the OR or can go to the radio intervention. Sometimes you have injuries of the subclavian artery. You can control to endovascular procedure. So if the patient is stable, you can go. You can go to the OR if you have the vascular procedures in the OR, and can you try to control the proximal control of the bullet, the injury, and you can put the endovascular to try to avoid more injuries when you go in the surgery to exploration of the subclavian artery. But if you don't have, you can go to open the subclavia and exploration subclavia. If you have to exploration the subclavian artery, you can go through, depends of the portion of the subclavian artery you can go. So the control of this artery, you need to know where is the bullet injury of the artery to control proximal control of this injury. You can go to thoracotomy, you can go to subclavia only incision on clavicular area or not. So I believe that this patient is more important is to know where is the trajectory, and then you can go to control. If you go to subclavia, you can show if the results you have. That's it.
Thank you, Dr. Collet. Let's go with Baghdad. Dr. Untrat, your comments, please.
Yeah, Dr. Qasim and Dr. Collet pretty much said everything. So in this case, it's the trajectory. So the initial workup on the X-ray, if you can't tell, if there's no exit wound, to see, try and see where the bullet went, if there's an exit wound, if the bullet's lodged somewhere. So this is lateral to the humerus, and the bleeding is presumably in the subclavian artery or proximal to the. So it had to go from lateral to medial. And what I would do is, if there was evidence of he's in shock because he's bleeding externally, but also it involves a hemothorax, then I guess the option is, if you have the hybrid room, go to the hybrid room and put the balloon in first in the ER Foley catheter. If that's tamponaded, fine. Then go to the hybrid room or the OR after that, or if it tamponades, the OR, either hybrid or conventional, or if you don't have a hybrid room, angio to see if they can determine where the bleeding is. Perhaps like there are other presentations here, use stents in the cath lab to try and get control of the injury. And if you don't have that, you don't have a hybrid room, you just have the operating room. If the injury involves a hemothorax on the right side, then and the patient is not it's not controlled, I would do a median sternotomy to get control of the nominal artery, and then from there the proximal subclavian artery. If it doesn't involve a hemothorax, and he says he's a big guy, but regardless, in the operating room, you should, like Dr. Collet said, control of the axillary artery through the clavipectoral fascia anteriorly, and get control that way. And if you're in the OR, then I would try to put a shunt in the OR for damage control, and then worry about the definitive repair after that point.
Thank you, Dr. Untrat. Dr. Ginsburg, your comments, please.
IBID.
All right. Good enough.
Ditto.
All right. Thank you very much, sir. Any other comments before we return to Dr. Price? Okay, back to you, Dr. Price.
Okay, yeah, those are great comments. Everyone's really spot on. So we actually placed a Foley catheter balloon into this bullet tract, which did provide some temporary control. His venous blood gas shortly after arrival, and once MTP was started, showed a pH of 6.9. He was hypercarbic with CO2 of 81. His bicarb was 16 with a base deficit of 18, and his hematocrit on that gas was 36. This is his chest X-ray. So you can see, as everyone kind of mentioned, to rule out that hemothorax, which he did have. It's kind of hard to see on this X-ray, but he does have a destructive chest wall injury there with some missing fragments of ribs, and then the retained bullet there in the near the mediastinum. So with that new information, we kind of talked about the operative approach. I don't know if you want to do another round of comments here or just move on.
I'd like to just add on, Dr. Price, that once we saw that chest X-ray, as you recall, we immediately used the ultrasound probe to interrogate the heart and make sure that there was no pericardial tamponade that needed to be addressed immediately before heading back to the OR.
Yes, thank you for that.
Thank you, Dr. Yee. I don't know if anyone wants to comment, at this quick juncture. Okay, Dr. Intl, go ahead, please.
Just what are your options there? Do you have a hybrid room, or what?
So this is
what are your?
So we don't have a hybrid room as an option there. This is our level 2 community trauma center. So we have 4 operating rooms that are designated trauma, or actually I think it's 3 designated trauma rooms that are just adjacent to the trauma center.
We have three operating rooms. However, Vascular is able to do TVARs, and they are able to do that in the OR.
But that's using C-arm fluoroscopy, right?
Correct.
Correct.
So have you controlled his hypotension, tachycardia, and have you stabilized him by then?
No, so at this point, he's still very tachycardic with a heart rate in the anywhere between 140 to 150s and hypotensive.
Mm-hmm.
Bleeding does seem to be controlled, at least externally.
He also had a pulseless extremity distal to where the bullet hole was.
So that leaves Dr. Calais. Any comments, questions before Dr. Price continues?
No, I believe you don't have results in these situations, because see only the operation. In this situation, you have a bullet who comes from the shoulder to the mediastinum, and you have a hemothorax. So in this situation, I go to the patients to OR, and sometimes if I don't have too much to open the sternotomy. So in these patients, I go to make a right thoracotomy, prolonged to the left side, and to explore the injuries. If I see the injuries is in the subclavian artery or vein, I go to put a stent, try to put a stent through to the thoracotomy. You can see, well, a clamshell incision, you can go to control in the situation, and then you can explore the arteria later.
All right. Thank you, Dr. Calais. Anything else before Dr. Price continues?
I would also keep in mind that because of the chest wall disruption, that you may actually have some intercostal vessels bleeding and giving rise to the accumulation in the right chest. So keep that in mind as well before you embark on thoracotomy and a supraclavicular incision to control the bleeding.
Thank you, Dr. Kassim. Okay, Dr. Price, back to you, please.
Okay, so we did begin with a right anterior lateral thoracotomy. He had a large volume hemothorax, which we evacuated. He had injuries to the right lower lobe, multiple injuries, and as well as a palpable bullet fragment within the lung parenchyma. We were able to glance over at the pericardium, and that was intact. It was not violated. There was no evidence of tamponade. We initially performed a tractotomy using a GIA stapler. We oversewed several vessels that were bleeding. However, this was inadequate. There was also a large air leak coming from a bronchial that was just making control of the bleeding very difficult, making visualization difficult. So we ended up just quickly doing that should be a non-anatomic wedge resection of the right lower lobe using the GIA. Again, there was this destructive lateral chest wall injury. However, there's no injury to the upper lung. There was no bleeding coming from the apex of the pleura. So at this time we had the finishetto in place. So we started to release that. And as soon as that was released, there was torrential bleeding coming from the bullet tract, which was tracking through kind of down through the axilla, through the soft tissues of the chest wall, and then into the chest wall itself.
So if you just go back one, I'd like to add a little bit of commentary. So as you recall, Dustin, we actually first started with a chest tube because I wasn't sure if the hemorrhagic shock was into the chest or if it was here. And so we were going to start off with a diagnostic chest tube to see if we got a lot of blood. And as you recall, you put your finger in. Even before we put the chest tube in, the blood was spurting around your finger. So you made the incision for a chest tube.
That's why I left that out. So we didn't actually place a chest tube. We made an incision for a chest tube and then quickly converted to a thoracotomy.
Right. So going into the chest, I was worried that it was going to be like a pulmonary vein or some sort of intrathoracic, source of the hemorrhage. And so that's why we ignored the arm for a moment. We said, okay, well, that's ischemic, but we were going into the chest to see if he was exsanguinating into the right thoracic cavity. He had a decent amount of blood.
Can I make a comment real quick, Dante?
Sure, go ahead.
I mean, fine, but in reality, think about it. I think if you didn't have a chest x-ray and you had to rush this guy back, then, spending any time putting a chest tube would be really a good thing to do, because you can put it on both sides if you don't have a chest x-ray and just rule out, bleeding from either side so that you knew what approach to take. But in this case, you did have a chest x-ray and you did know that it entered the chest since there was, that big injury. So I understand your thought process, but in reality, it turned out to be, first of all, redundant. You never ended up doing it because he did have a chest x-ray, but for the next time.
Yeah. But I was doing that basically to explain sort of in a little bit more detail that final bullet point, the bullet point on this slide, because our incision to make the thoracotomy went across the missile tract in the subcutaneous tissue. This guy was very muscular and very big, so he had a lot of soft tissue. So I think, in retrospect, Dustin, when I'm thinking about this case, I think that torrential bleeding that you got initially that misled us into the chest was probably coming from the bullet tract, but we didn't realize it until after we released the finishetto and after we finished the thoracic portion of this case.
Yeah, it's possible.
That was the kind of additional commentary I just wanted to sprinkle in.
Okay, thank you.
Thank you, sir.
So bleeding from this tract, kind of, like I said, it was up towards the axilla through the soft tissues. So we ended up placing another Foley catheter through this tract itself and inflating the balloon. This did provide some temporary control, but it was rather inadequate. We quickly made a right infraclavicular incision along the delta pectoral groove. We extended it down onto the right arm, which included the bullet wound itself. As Dr. Ye had mentioned, this guy was very large. He was muscular, and then to complicate things even more, he had a very large hematoma of the shoulder as well as the chest wall. So this made for the dissection of the axillary and subclavian vessels extremely difficult. He continued to hemorrhage around that Foley catheter. We had attempted multiple different methods of compression, including just finger occlusion. We packed some combat gauze into the tract as well as regular laparotomy pads. Really, I think the best thing that helped was just finger occlusion. But again, that took away, one hand from the operation. So given that it was such a difficult dissection and we just weren't getting control, we decided to perform a median sternotomy to get more proximal control at the brachiocephalic artery. So this was done. This was done rather quickly, and we were able to get control. And once we got the clamp on the brachiocephalic, the bleeding did subside. The patient at this point, let me see if I have it on the next slide. The patient at this point was getting a very large amount of blood. He was at probably 30 to 40 units at this point of red cells, as well as FFP, and was becoming coagulopathic. Once we did control the bleeding with the brachiocephalic clamp, we were able to dissect out the axillary artery. And this was a complete transection of the artery. It was distal to a deep arterial branch. It was hard to say what it was. My guess is it was a subscapular artery. Once we were able to dissect proximal and distal, we were able to move the clamp from the brachiocephalic to the axillary artery. There was an additional injury to the axillary vein. However, this was not amenable to repair, and this was ligated. Like I had mentioned, the patient was coagulopathic. He remained unstable. We had then gotten word that the blood bank was running out of blood products for this patient, and at one point said that there was no blood products available, and they were working on obtaining more. So this, in addition to him being coagulopathic, created even more of a complicated picture. He was getting then crystalloid at this point just to give him some volume. So the question was now, how do we manage this vascular injury? We have a transection of the axillary artery. We have an injury to the axillary vein that's now ligated. So what would everybody do in this situation with limited blood products available in a coagulopathic patient that's unstable with
Also, the anesthesiologist was pushing epinephrine pushes at this point. The heart rate was 170s, blood pressures were in the 60s, and we had just put the last 4 units of blood in the entire hospital into the Belmont, which was running at somewhat around like 500 a minute.
Baghdad, Dr. Contract, your comments, sir.
Yeah, so just to back up a little bit, there was a clue that you mentioned earlier that the extremity was pulseless. That was one clue, which would have directed me to get control early on to the innominate artery or brachiocephalic artery. And then the other clue was the title of the presentation. So I think I was biased by that. But then you said afterwards that as you were taking care of him, he got this big hematoma at the right axilla. So, the pulseless extremity, the big hematoma, then I wouldn't have tried to get control through the axilla, through the clavipectoral fascia. But here in Iraq and Baghdad, I probably would have gone, and I'm biased because of the title of the talk, but based on the expanding hematoma, absent pulse, and the chest x-ray, I probably would have gone straight to a median sternotomy, gotten control of the subclavian artery early on, and then explored the right chest through the median sternotomy. So I would have, you could feel what you found basically, and then we could see that the bleeding was coming from the axillary artery. And in your case, had I done what you did, just do a thoracotomy, I think you probably could have gotten control of the subclavian artery up in the apex. It would have been more difficult, but you probably could have got, I don't know what you found, but you probably tried to do that. Or I guess you couldn't because you went to the sternotomy right away. But anyway, so faced with that, in this case, you have proximal control, and then that should slow down the bleeding. And then I would try to find if you could see the two ends, or regardless, I would, for damage control, I'd try to put a shunt in, and then get control and pack the wound for any collateral bleeding, and then take him to the ICU and let things calm down. If you don't have control, then I would try to ligate proximally as far close to the injury as you could, and then try to do some kind of damage control procedure. So from proximal to somewhere beyond the hematoma in the upper extremity or in the distal axilla. But in any event, in this case, it sounds like he's also going to have damage to the brachial plexus and a severely incapacitated right arm. But I would try to do damage control to get, you get the proximal control, distal control, and some sort of temporary shunt to tide him over until things stabilize down physiologically with him in the ICU.
Thank you, Dr. Untrak. Dr. Calais, your comments, please.
Yes, I think it's very important. Then you can have control of the brachycephalic trunk through the anterolateral, right lateral thoracotomy, prolonged to the left. You know, you need to avoid to make a sternotomy in this situation. You can control the proximal portion of the subclavian by the decision 2. And I have a case like this. So in these situations, I put a vessel loop through the brachycephalic, and then I call for the vascular, can put a catheter through the femoral artery, and to the subclavian artery, he put a balloon. And then he can try to make a shunt or put a shunt, a stent through this situation. It's very difficult sometimes, but you can proximal control the hemorrhage of the subclavian artery in this situation using this procedure. The great problem in the situation is the venous injury. The venous injury is more difficult to control, but sometimes you can control with compression and put a damage control. You can put pads on the upper of this region and compress. And then you can, if you can resolve by endovascular in this moment, you can now controlling the control the proximal artery. You can control to the distal artery. You can make catheter, put a catheter through the axilla to the brachial artery in the situation and try to conjunction to put the stent. So you can control the distal portion, usually to put a balloon in this situation, and then stop control distal portion of the artery. And then you can put a stent or can put a shunt, or you can make repair the artery, use a graft, saphenous graft in this situation. So in this situation, it's very difficult to do. I believe it's very, very, very difficult. And the most blood producers and the coagulopathy, these patients may be very, very unstable. So at this moment, I have to try to make a control only the hemorrhage and try to recover the patient.
Thank you very much, Dr. Lay. Dr. Kassim, your comments, please.
Well, in a case like this, having had a bad experience, something like this that happened to me when I was in Croatia during the Bosnian War. So I remember how horrible it was to have a patient die of hemorrhage. So I think I have learned from my bad experience that when somebody is bleeding so profusely here, you have to be accurate in what you're going to do so that the bleeding stops precipitously. You can't afford to lose more blood and then run out of blood product, even a big hospital like yours. So I think I would probably take a different approach to my friend, Dr. Untrak. Instead of median stenotomy, suspecting the patient probably has a vascular injury somewhere under the clavicle, I think I would have resected the clavicle immediately without resorting to anything else to stop the bleed mainly, because that is where the money is going to be. Either it's subclavian or axillary artery in this incident is most likely axillary artery, and I can get control of the subclavian artery and look at the subclavian vein as well at the same time if I resect the mid portion of the clavicle. And I can do that pretty quickly, as opposed to doing a median stenotomy and then going through a very muscular man like this. It's going to take time and exhaust my my availability of blood product. So I think that's what I probably would have done to stop the bleed here. And but in this case, you know, you are in the operating room and you have given everything that you have, and you still keep the patient alive through slow infusion of epinephrine to keep his blood pressure at least in the 60s, pulse rate is sky high. You are in a very difficult predicament at this moment.
Thank you, Dr. Sadie. Dr. Ginsberg, your comments, please.
Basically, I mean, everyone has given their opinions. I think you just have to look at this case and where they were at that time. And basically, they have a still unstable, probably almost fully exsanguinated patient who is coagulopathic. And in light of all these situations, basically you don't have much. You've got, once you've got the exposure that you've done already, which you said I think you've already said what the patient had, right? Or not?
Yes.
Yeah, so in light of what the injury, which was axillary, and you got continued bleeding, the real question is, do you put a shunt in with the possibility of continued bleeding from that site, or do you just ligate and get out? And I think that's really the only choice you had. Trying to do it like Dr. Collette, who I obviously respect highly, the same as the rest of you. I don't think you have that freedom with this guy who's very, very unstable to do either a shunt or ligate. And I think that's all you have to rely on. Now, just a couple pointers. They were in the chest, so they did document that the injury was just pulmonary and not. You could look up and see that there's no exsanguination from the coming from any tissues from the mediastinum. So you basically ruled out brachiocephalic injury. Just remember, on the right side, the subclavian proximally goes above the clavicle and then dives down below the clavicle more medial towards its mid to distal portion of the subclavian. So yes, you can do a clavicle resection. Or one thing that I had asked them was, why don't you just splay open that whole area, which they did, but this guy was really big. I had to operate on him the second and third time, and he was extremely muscular. So I understand their predicament.
Also, as a follow-up, we did look up into the apex of the right chest. I have never attempted to try and get control from within the chest through a right thoracotomy because of the anatomy, as you stated. And so the decision to go into the sternum was colored by two prior experiences I've had. The first one 2 years ago was one where it was me and another attending were operating on the exact same injury pattern, axillary artery and vein, and the patient exsanguinated despite two of us trying our best to salvage the patient. And the feedback after the in the debrief was, you probably should have gone for median sternotomy. So I kept that within me, and then I recalled it during this case. The second one was about a year ago. I had a subclavian injury that I did in fact do a resection of the medial head of the clavicle, just as Dr. Kasim described, and it took me a while. It was not it was not as quick as I would have liked to believe I could do it, and so just weighing the limited resources that we had left, I felt that it would be much faster for me to just do the sternotomy, where I knew from visualizing the pericardium and the mediastinum that there was a clean field, there was no hematoma, there was nothing. I just, you know, gauged which can I do faster, and I felt that I could do the sternotomy and mediastinal dissection faster than trying to resect the medial head of the clavicle, and it's very muscular and distorted guy. So that's just some follow-up. The artery, it was like 4 or 5 centimeters of artery that was destroyed, and vein. So bridging it with a catheter or a stent graft was impossible. Even if we had vascular immediately available, which they were not, they would have had to drive in from home and the guy would have bled out to death by then. But it would not have been physically possible to bridge the tissue defect in the artery and the vein.
Thank you very much. Any other comments before Dr. Price continues? Go ahead, Dr. Price.
Okay, so
if I can make a quick comment,
yeah,
is that okay?
Yes,
Yeah.
please.
So I just want to say I agree with, and I think we all agree with Dr. Qasim that you need to get proximal control as quickly as possible. It's just what's the easiest way for each individual to get proximal control, and my feeling was with a big muscular guy, median sternotomy is just the skin, a little bit of sub-Q, and then the sternum right there. And I think for most of us, it's a very quick access with into the mediastinum. It's right there, you get control, and rather than going through the hematoma. I suppose for some people it's quicker this way. It wouldn't be for me to go through that's just in my experience. I just regretted them immediately, and with a big muscular guy. But anyway.
Mm-hmm.
Yeah, that's a good point. And I think, we certainly could have done that approach and done a sternotomy, and perhaps that would have been the better option to do that first and then get control of the brachiocephalic and then make our, infraclavicular incision and explore the artery. Yeah, the hematoma was, it wasn't a large, expanding hematoma. It was around, it wasn't completely evident at first. It only became evident once we started the dissection. So that kind of clouded that a little bit. But, I think if we had done a sternotomy initially, it probably would have saved some blood transfusions for this patient and gotten control quicker. But obviously that's retrospect. So as Dr. Ginsburg had alluded, we did end up ligating this vessel. We did not option for a shunt or obviously for definitive repair at that time. And part of our reasoning for that was like I had mentioned, their blood products were very limited at this point. They were trying to gather more. And he was also severely deranged metabolically. And our thoughts were, if we did shunt him and then do fasciotomies of the upper and lower arm, they were going to be further sources of bleeding, potential reperfusion injury, and could just make the clinical picture even worse. So we did, the most damage control thing possible and just ligated the vessel. So then to complicate things even further, once we ligated the vessel and got control of bleeding, he had anesthesia told us they had a lot of difficulty ventilating him. His peak airway pressures were very high in the 40s. He was getting very low tidal volumes. His abdomen was very firm at this point, and there was concern for compartment syndrome. So we did perform a decompressive laparotomy. He had this very large volume milky ascites that we presume was from the resuscitation. I don't know what else it would have been from, but I've personally never seen that. I don't know if anyone else has. It was interesting though. His bowel was very edematous, and we just placed a temporary vac dressing and just left his abdomen open. Once we had decompressed him, his ventilation improved substantially, and he improved overall much better from a hemodynamic standpoint as well. We then finished our damage control procedure. We placed a couple of chest tubes in the right chest, and we just closed the skin, left the chest wall just open. We then placed an Esmark dressing over the sternotomy, and the infraclavicular incision is another damage control method and just tried to get him to the ICU as quickly as possible. This graph on the other side, this is just showing his CO2 tracing, and you can see that spike in the CO2 intra-op, and then it leveling out after we opened his abdomen and got him to the ICU. So our start time for this operation was around 6:09 p.m., ended around 21:30. His total operative time was around 3.5 hours. We did transport him then to the ICU. He was getting little pushes of vasopressors in the operating room. However, he was not on any drips. And then when he got him to the ICU, he did not require any vasopressors. His coagulation profile is there, intra-op on the left side, and you can see his INR is very elevated, his PTT is very elevated. His TEG was rather deranged. He did get further resuscitation once he got to the ICU, and then shortly after that, got further coagulation studies, which showed much improvement. So postoperatively, his right upper extremity pulse exam was significant for a Doppler signal in the brachial artery. However, he had no signals or palpable pulses distally in the radial or ulnar arteries. He developed progressive cyanosis of the right hand and distal forearm. On post-trauma day 1, he returned to the operating room for closure of his sternotomy, as well as the laparotomy. He was developing worsening edema of the right upper extremity, and then on post-trauma day 2, fasciotomies were performed of the upper and lower arm, and then at that same time, the thoracotomy incision was definitively closed. We did consult hand surgery for assistance in management of his ischemic right hand. This is just a tracing of his CPKs. He peaked around 23,000 and then progressively improved. On post-trauma day 5, he was extubated, but then immediately was reintubated just due to inability to clear secretions, and hand surgery was following. They wanted further demarcation of his right upper extremity before doing any sort of amputation. We also spoke with vascular surgery just to get their opinion on any revascularization options, just to aid in healing an amputation site. So we did perform a CTA of the right upper extremity, and these are just, I don't have the video, I'm just not that technically skilled to put in the presentation, but I have some just cuts. This is a cut showing the axillary artery. This is just proximal to our ligation. And then right here, you can see right where it's ligated. This is essentially the next slide, or the next slice through the CT. As we come down the arm, there is reconstitution of the brachial artery there. This is the incision from this was the surgical site from the infraclavicular incision, as well as it was carried down on post-trauma day 2 for the fasciotomies. So this is his forearm fasciotomy. You can see some ischemic appearing muscle distally in the forearm. So on post-trauma day 13, he underwent a right subclavian to brachial artery bypass. This was done with reverse saphenous vein graft by vascular surgery, and this was done to aid in healing and amputation and trying to salvage his elbow. He developed a GI bleed and was started on a heparin drip. However, he's developed the GI bleed after starting the heparin drip. This was then stopped, almost immediately after it was started. He did not require a scope or any blood transfusions for this. On post-trauma day 14, he underwent a transradial forearm amputation, and then a complex closure. He got a split thickness skin graft, which was actually, the skin was taken from the amputated portion of his extremity. And then on post-trauma day 17, he was extubated. So we can talk a little bit about how we would manage the the ischemic extremity for ligation and what people's thoughts are on ligation of this and the outcome.
Dr. Collette? Go ahead, Dr. Collette.
Muted.
Go ahead, Dr.
He's muted. Dr. Clay's muted.
Dr. Clay, you're muted.
Okay. I don't think it's a very interesting case. It's very interesting result in this patient. I think that sometimes the subclavian portion, proximal artery, axillary artery, you can ligate this artery. You can have perfusion by collateral if there is, it's very possible. So you can sometimes you can do this. It's a very interesting case. So that's it.
Thank you, sir. Dr. Rondas?
Yeah, so really, I think this just an amazing case, because here this patient was all the way to the event horizon of the black hole, about to get sucked into the black hole. And I think you made the very wise, courageous decision to salvage life, then limb, then eyesight. That he's going to lose the arm and do what you did. And I think the mistake most of us make is persist too long in trying to, do some, try to do too much with the salvage. So I think that's, that was the perfect decision. And then even had you been able to repair the injury to the subclavian artery, then I'm sure there would have been extensive damage to parts of the brachial plexus. And I don't know if you were able to determine afterwards, did he have good active flexion extension, full strength in the elbow? And, so even had he, you've been able to not do the amputation, probably the hand would have been significantly impaired based on whatever damage was done to the brachial plexus. So I think this result is superb. If he has good control of the elbow and he has a forearm amputation, he can get good rehabilitation. So I'm just impressed with what you did, that he was so far gone that used up all the blood available and he was dying, and you just did exactly what I think was the appropriate thing to do, and say, look, save his life, and then, accept the reality that he'll lose the arm, his right arm, and, but it saves his life. And then you're able to get a very distal bypass as opposed to a higher one. So I think that I wouldn't second guess anything you did here.
Thank you, sir. Dr. Kasim?
Well, there is a saying, for want of a limb, a life should not be lost. And in my case, way back when I was attending in Europe during the Bosnian War, my patient actually died on the table because we did not have all these blood product and so much volumes of blood available for that particular patient. And that case always gives me a nightmare. Once in a while, I dream about it, and it's horrible. But you did exceptionally well in a case like this. You literally saved this man from sure death, and at least you managed to keep him alive, and he has a so-called useless limb, but he will manage. He will somehow rehabilitate himself and get his left limb working properly, and he will do just fine. And I think what I'm learning from this case is you have to be aggressive and yet compassionate, and do the right thing to save life. And you, of course, did that to this particular patient. And I take my hats off to you. Thank you so much for showing this case.
Thank you, Dr. Kasim. Dr. Ginsburg, comments, please?
Basically ditto for everything that was said. I don't want to, we need to throw all the dirty laundry though, right? Dustin,
Yeah.
why don't you tell him what happened to this guy's leg? I mean, that's more important. Not more important, but that's of an interest. And I
Yeah,
think
so I was going to comment on that too. But just to kind of things to learn, I think, from this case, I think in retrospect, I wish we would have done this median sternotomy quicker. I think he would have gotten less blood products. We wouldn't have run out. It may have provided some further options for potentially shunting him. Obviously, I'm still, happy that he made it through this. I didn't think he was, and he's in very good spirits. He's extubated. He has a strong family support. His mother's at bedside. His girlfriend's at bedside, and he, from a mental status, he's doing very well. He did develop a further complication.
One second, Dustin.
Yeah.
Let's play devil's advocate here. What if you would have just gone into that tract when you first exposed it, found the axillary artery, and gotten control of it, and everything would have been fine, spending the extra 2 or 3 or 4 minutes? I don't think in the overall scheme of things, that would have made a difference compared to doing a median sternotomy in a guy who's very sick. And then the next thing you know, this guy develops a median sternotomy infection, a sternal infection, which carries a very high morbidity and, mortality actually rate also. So don't, only you were there with Dante, so you guys just know how much time you actually spent. Obviously, if you were spending a lot of time trying to control it for a half hour or, that amount of time, then yes, median sternotomy after a few minutes when you can't get control. But otherwise, I don't think there was anything wrong with trying to, get to it, because you knew it wasn't in the chest.
It certainly didn't seem like a very long time, but I know time flies when you're in the operating room in a tense situation like this. So I'm sure things could have been done a little bit quicker. But again, that's like Monday morning quarterback, in retrospect. So it's hard to say. I don't regret trying to get control through an infraclavicular incision first, because it did not appear that a hematoma had extended all the way into the, subclavian vessels. And, that didn't become evident until we actually dissected down and got down towards the clavipectoral fascia and started to split the fibers of the pec. So, it's difficult to say, but I think there was probably some room for a more expedited approach. And then just to comment on what Dr. Ginsburg had mentioned, it's unrelated to this actual trauma to his arm, but he was placed on I mentioned he was placed on a heparin drip, and then that was stopped for the GI bleed, and then he ultimately was placed on Lovenox or enoxaparin as a prophylactic dose for just DVT prophylaxis. He ended up developing, we presume to be HIT. He developed clots in his left lower extremity, which I got called one night, and he had basically a pulseless left foot and was complaining of pain. And I didn't include those images in this presentation, but we obtained a CTA, and it showed a intimal injury in the SFA, just distal to the profunda. He did have a arterial line in that location. So he had basically 2 areas where there was an intramural hematoma. And then he had extensive clot burden distal to his trifurcation, his lower leg. So he ended up going to the operating room with interventional radiology as well as vascular surgery for multiple different attempts at re-vascularization, both percutaneously as well as open bypass procedures. They did extract white clot, so we presume this was heparin-induced thrombocytopenic thrombosis. He was started on argatroban They were unsuccessful though revascularizing his leg. Unfortunately, he was in the operating room for I think 24 hours. So he ended up getting a below knee amputation. So he now has his right upper extremity amputated at the elbow, as well as left lower extremity BKA, and that's still ongoing. That was just done about a week ago. His below knee amputation.
I think,
despite this, he is still in spirit, surprisingly, and is thankful to be alive and be family. But yeah, an unfortunate complication.
Yeah, it looks like Dr. Kasim had a comment.
Well, just want to tell you this, that when I came back from my tour in Croatia during the war, when I didn't do very well with a shoulder injury, and I went back to the morgue and started to learn how to do clavicular resection. And contrary to what Dr. Untrak says, it is not really that difficult. And now that I have done a couple of these, and I can get into the subclavian, on the right subclavian rather quickly. I worked out all the details, working it in the morgue. It's one of the armamentarium that you should have, and sometimes it'll become useful in treatment of patients like this. But if you are comfortable doing median sternotomy, it's perfectly okay as well. But it is, I'm here to tell you, it is not that difficult to do a clavicular resection. Thank you.
Dr. Kasim, I know we're a little bit over time, but I'm kind of interested because I think I've only done maybe 3 or 4 of them in my career. And usually, I think in 2 of them, the clavicle was actually fractured by the bullet. So it was sort of resecting just part of the head of the clavicle. But any tricks that, since you went to the morgue, that you employ? I'd like to hear them. I mean, it's not like we're doing these every day of,
right. The anterior part of the clavicle is easy to expose. It is the back and the posterior part of the clavicle. That is when that you have to have a special tool for that. And you have one of these rongeurs that we used to use in olden days to do thoracotomies. And then you slip one of that in and then pass it through. The subclavius muscle comes out very easily, and you are able to lift the whole thing up rather quickly.
Yeah. Yeah, I like the rib, where you hook underneath the rib.
Right.
To, that instrument.
Pigtail, the pigtail rougine.
Yes.
That's what they use in the UK, that one. Yeah, the right or left and whatever. Yeah.
Right.
Yeah.
I use a penetrating towel clip to grasp the head of the clavicle, and then I'll pass a Kelly underneath the dissected clavicle and grab the giggly saw. And that, I mean, I've only done it, I think, once, in an actual patient. I've done it in the cadaver lab when I used to teach the asset course, but it's been a while since I've taught that.
But like you say, when you're in the operating room doing something difficult like this, your mind is going in many, many directions, and you take the easiest route that you feel comfortable with. And of course, that's what you did.
Yeah.
Exactly. What works for the individual surgeon? What's the easiest route for them?
Right.
So, Dr. Price, were those your closing comments, or are they still?
Yeah, that was my closing comments. So I don't have anything in addition.
Okay. Anyone else have any additional closing comments? Bear with me a second.
If
I'll share the
Dr. Price, one closing comment. Dustin?
Yes.
The next time you present at Panamerican Trauma Rounds, you tell your father about it. I want to hear what he has to say. Dr. Price's father is a distinguished trauma surgeon on the west coast of Florida.
I wouldn't say
where
distinguished.
Where?
He's at Bayfront Medical Center.
Where is that? Tampa?
In St. Petersburg.
Okay, I live in Sarasota, so if I need, I'll look him up, whatever.
Oh,
If I need
I
trauma.
just-
Well,
Yeah.
you're gonna be you can watch this presentation at the Panamerican website later this week, so you're gonna be proud of Dustin. Anyway,
Can I just make a quick closing comment and ask a question?
Of course.
Yeah.
Go ahead, please.
Yeah, a question that I'll ask, and then I have a quick closing comment. So what was you say amputation through the elbow or through the forearm, and could you determine what neurologic injury he had? Because I think extensive brachial plexus neurologic injury, he would have lost the hand. The hand would have been useless, and if he has a functioning elbow and a good forearm stump, he's actually in much better shape that way. So if you can answer that, what was the injury to the brachial plexus, number one? My comment was, for a young surgeon, I think there are two good things you did. One was you knew at the right time, when it was your last chance to do the right thing, to ligate and get out and save the life and realize you're going to lose the extremity. Number one. Number two is, after the fact, when everyone's saying, no, don't worry, you're still saying, okay, I should have done next time this differently, that differently. In retrospect, you were there, the decisions you made, and that's superb. I think, too many surgeons get egotistical and they think they're great. I think that's great right there, that you still say you still think you could have done better, and you should next time do this. They're superb for someone so young. Some people never get it, and too many older surgeons, never learn that. So you learn that early on in your career. Superb.
Thank you for those comments. For the question about his arm, so he did have some motor function of his elbow. Unfortunately, he developed an infection of the amputation site. He ended up going back for debridement and ended up with a elbow disarticulation and closure. That's his definitive operation as of right now, but things are still ongoing, as I had said. It sounds like his vascular graft or bypass graft that was done to assist with amputation had thrombosed when he developed the hit. So that complicated things.
One follow-up comment to Dr. Entrock's point. When we decided to go life over limb, I made the decision. I said, okay, we're not going to half-ass this. We're going to commit for real. And that was actually learned through hard experience. I don't have any military experience, but I was involved. I was one of the surgeons that treated patients in the Boston Marathon bombing. And when I was at MGH, I had a 70-year-old who had his leg was injured by the improvised explosive device, and he came to me with a mangled extremity and an injured SFA, which I, as a young surgeon, 2 years out of fellowship at that point, had the ego to dissect down, expose the artery, expose the injury, shunt it, okay, and say, oh, I can salvage this limb. And my boss, George Velmahos, came in the OR. He took one look at the monitor, one look at the leg, and he said, you need to ligate this right now or else this patient's going to die. So I took his advice, and as soon as I took the shunt out, ligated it, pressors came off, the patient stabilized, and then in the next couple of days, we formalized his amputation. But I did learn through the mistake of in a previous patient that in a patient in extremis, trying to shunt them, the re-vascularization, the reperfusion can actually be a hindrance and a liability rather than an asset. So that's why I didn't even consider shunting in this case, because I learned it from hard experience last time.
And as Dr. Kasim said, and in my experience at the trauma center for the last 30 years, we've had the 2 or 3 patients where we become very resistant to just ligation and acceptance of an amputation, and patients have died trying to salvage.
We want to save the last closing comment for Dr. Martos, but before Dr. Martos, does anyone else have anything else?
Well, I'm so glad Dr. Ginsberg participated today. I learned a lot from him again.
Kasim, it's always you that I learned something.
okay, another great meeting. I'd like to say thank you very much for Dr. Ginsburg and Dr. for supporting Dr. Price, Dustin in this presentation. I would say another great meeting. Dustin, amazing job. We all keep learning with each other for 11 years now. I would like to ask everybody to support the Panamerican Trauma Society. Please ask people your residents, your fellows, your friends to join the society. And this presentation going to be available at the website in a few days. Okay, thank you very much. Looking forward for meeting you all next week. Thank you.
Thank you. Thank you.
Thanks,
Thank
everybody.
you.